Now we have a very interesting X-ray of the chest. You can simply try to see what is the finding that you are able to see. So you can take a moment and try to see what exactly you are seeing in this X-ray. If you're done, what we'll start is we can simply check this costophrenic angle. So this is the diaphragm, this is the diaphragm, and this are the costal margins, so rib margins. So we can very clearly make out that both sided this costophrenic angles are open, means there is no effusion. So effusion is not there here also, here also. If you try to see the lung margins here, we can very clearly make out that lung is spread almost up to the costal margin here. So how we can make it? We can make it very simply. What we have to see when we want to say that we need to see the lungs, we need to see the bronchovascular markings. So bronchovascular markings will appear reticular, means lines like white lines, which usually contains bronchial artery, bronchial vein, pulmonary arteries, pulmonary veins. So usually pulmonary artery or their branches spread from this hilum and they reach up to the most peripheral portion. So we can simply see those bronchovascular markings, the fine white lines. So these white lines which are almost spread up to here, this all is lung. So in fact here the lung is spread up to the costophrenic angle. So this is all lung. But when we see on the left side, this is the left side, what we can see that if you can see in this area, we can very clearly see a white line running from this. This is all lung. So I'll erase this so that you can see this very well. So if you can see, this is the lung margin. So this is all slightly collapsed lung. If you can see, this is the margin, this is the lung line, and out of this lung margin, there is no bronchovascular markings. So this all this this triangular portion, this much is all air. So bronchovascular markings are not there. So in short, this is a pneumothorax. This is a pneumothorax because you'll not be able to trace any bronchovascular markings in this area. So this is a this is a rib margin, this is a diaphragm, and in this area, this triangular area, you'll not be able to see the white lines which are there like these. We can very nicely see here, these are the white lines, reticular lines. This reticular lines all, they represent bronchovascular markings which are not here, and we can see air is present here and the lung is collapsed. So this particular case had a gross pleural effusion which was tapped, and after this tapping of this patient developed this pneumothorax. So this was a post tapping pneumothorax. Most of the time such small pneumothorax don't need any ICD. Such patients usually improve only with air. We usually give air by nasal prongs or masks, and most of these small pneumothorax they resolve on their own. But we have to do a repeat X-ray, maybe after 12 hours or 24 hours, depending on patient's condition. Is patient's tachypnea, shortness of breath, RR is improving, worsening, or if the patient has tachycardia, then definitely we need to repeat the X-ray. And if this pneumothorax is worsened or increased, and if it is causing collapse of the lung, so next thing which will happen will be shifting of this heart towards the right side, towards the opposite side. So there will be not only the collapse of the lung, but the mediastinum will shift, the heart will shift, that will more stress on the heart, so that there will be tachycardia, there will be shortness of breath. Patient may need ventilation or NIV or invasive ventilation. And most of the time, simply putting an ICD, intercostal drain, will resolve this issue. So this X-ray very typically shows a very beautiful pneumothorax that was post pleural effusion tapping. That's all for now, and thank you.